Associate Professor of Neuropathology, Section Head of Muscle and Neuropathology, and incoming Neuropathology Fellowship Director at Duke University. She received her MD and PhD from the University of Kansas School of Medicine and completed her anatomic pathology residency and neuropathology fellowship at the University of California, San Diego, where she subsequently practiced diagnostic neuropathology and led the neuromuscular pathology service. Before her appointment at Duke, Dr. Jones was a neuropathologist at the University of Iowa, where she expanded her neuromuscular expertise, seeing consultations from around the country while working with a talented group of neuropathologists and neurologists. She has recently moved to the East Coast to continue to practice academic neuropathology with a focus on the muscular service at Duke. Dr. Jones' research interests lie in the area of genetic muscular dystrophies and myopathies. She is very active in the AANP and is a member of the CAP Neuropathology Committee. I will now turn it over to Dr. Jones.
Thank you so much. I am really excited to be here today to continue to talk about muscle pathology. And today we're going to be focusing on congenital myopathies. And as a disclosure, I am a consultant for Astellas Gene Therapies, but my work with them will not be discussed here today. And the learning objectives you have already had a chance to take a look at. And for those of you that joined us for the muscular dystrophy session last summer, you'll know that these two books are ones that I really use as my go-to Bibles, if you will, for muscle pathology. And just like muscular dystrophies, there are many, many pages dedicated to just understanding congenital myopathies. And so we're not going to be able to touch on everything today. It's not going to be very comprehensive, but what we will do today is we're going to focus on common things that present themselves as congenital myopathies. We're going to talk about some tips for diagnosis and to help you in your everyday practice, and also some pitfalls to avoid. So to start, we have to start at the beginning. Myopathies, just like we did with muscular dystrophies, are a disease that's characterized by muscle weakness, very simplistically. When we talk about congenital myopathies, what we're describing here is weakness that's present at birth or in early childhood. So that's the technical definition. The reason there's an asterisk here is because you will learn, or you may already know, that congenital myopathies don't always present in birth or in early childhood. There are many exceptions to that rule. However, they are still termed congenital myopathies. These are also genetic diseases, mostly inherited. However, they can show up as de novo molecular alterations. And just like the muscular dystrophies, these start with a gene alteration that's going to change your protein structure that then is going to lead to muscle disease. And if there's one thing that you need to know about congenital myopathies, or one thing I want you to think about that helps you put them into a category, is that these are structural abnormalities that occur during the congenital myopathies. Not every single one is structural, but most of them are going to be structural. And so it really helps to think about them in that way. And because they are often structural abnormalities, the genes that are altered encode proteins that are related to the sarcomere, a structural component of skeletal muscle, the sarcoplasmic reticulum, the T-tubules, the triads, and then also some that are involved in myoblast growth and differentiation or muscle energy metabolism. And as many of you know, I'm a very visual person, as most of us are, because we're pathologists, right? So it helps me to see the structure, to think about where these genes are creating proteins, where they're located in the muscle. So as I mentioned, sarcomeric proteins are heavily represented in the congenital myopathies. And so it helps to think about where what the sarcomere structure is like and where these proteins are located to understand what you're going to be seeing. So as a reminder, a sarcomere extends from one Z line over here to another Z line over here. And I was just going to, can you all see my mouse? Let's see if I can get a little bit of a confirmation here from someone to make sure.
Yep.
Okay, thank you. So from Z line to Z line here, and what you can see is in blue, these are the actin thin filaments here and here all along. And we also have the myosin heavy filaments here, or thick filaments here. And we have proteins such as nebulin and actin that are part of the actin thin filament that are going to lead to diseases that we'll see today. They're also titin here is the largest protein in the human body. It is extremely important for the function of the sarcomere and extends from Z line to M line. And TTN or titin myopathies can lead to a number of various congenital myopathies. And for those of you that were present at the DSS a couple of weeks ago, Nicole Becker from the University of Iowa presented an excellent case of a TPM3 related nemaline myopathy, which is due to tropomyosin alterations that are also found in the sarcomere. In addition to sarcomeric proteins, proteins that are also involved in the sarcoplasmic reticulum or the T-tubule or the triad can also cause congenital myopathies. And so to start a review of these structures, the sarcoplasmic reticulum is a specialized smooth ER that is just found in skeletal muscle. It wraps around myofibrils, and its main job is to store calcium and release it at the appropriate time. The T-tubule is an extension of the sarcolemma or the cell membrane that wraps around as well. And the T-tubule is where the signal from the nerve eventually extends to the sarcolemma down to the T-tubule and down and wraps around the myofibril. And when that electrical signal comes through the T-tubule and it hits this terminal cisternae of the sarcoplasmic reticulum on either side, which is called the triad, that stimulates the sarcoplasmic reticulum to release calcium to start a contraction of that skeletal muscle fiber. And if we look at it in a more diagrammatic method, you can see here is the sarcolemma with the T-tubule going down, sarcoplasmic reticulum over here, and together that makes a triad. And some proteins that we'll talk about today are going to be our ryanodine receptor encoded by RYR1. That is a very common gene to be seeing in congenital myopathies. And this is the ryanodine receptor is actually a calcium channel where the calcium moves from the sarcoplasmic reticulum towards the T-tubule. Selenon, which used to be known as SEPin1, is another gene implicated in congenital myopathies that's fairly common, and it encodes selenoprotein, which is also a sarcoplasmic reticulum protein. And then some genes that are involved in centronuclear myopathies, MTM1 and DNM2, we'll also talk about today. So in general, when we're talking about congenital myopathies, these can be due to dominant recessive or X-linked recessive alterations in a number of different genes. Some genes can have both dominant and recessive disease within the same gene itself. And de novo dominant mutations can be fairly common, particularly in RYR1 and ACTA1 related disease. So there will be no family history to help you in those cases. The genetics are pretty complicated because alterations in the same gene can cause more than one pathological feature. And here's some examples of that. So if you follow RYR1 here as our example, you can see that a rod myopathy can be due to RYR1. So can a core myopathy, so can a central nuclei, so can a combination of rods and cores, or fiber type disproportion. And so one gene alteration can lead to various different pathologies. And that is not just seen with RYR1, ACTA1 and others are also seen here. And likewise, the same pathological feature can be caused by multiple different genes. So rods can be due to alterations in ACTA1 or NEB or other genes listed here. So that's what makes it a little bit complicated. And you may have noticed that learning objective number 1 was that we should summarize frequently encountered congenital myopathy clinical presentations. So you may be asking, isn't this a neuropathology teaching rounds? Why do I need to know about these clinical presentations? And this is just my reminder to everyone that there are no silos in neuromuscular pathology. You can't practice muscle pathology without your clinical information, without your neurologic exam. That being said, many of us, unfortunately, get a practice at referral centers, right? So we're getting these muscle biopsies. They may not have clinical history. So you do the best that you can. But in a perfect world, there are no silos. We have this clinical information that's really helpful to us. So the first thing you do when you look at a biopsy that's coming in, if you look at the clinical information, that can help you actually start to get your mindset ready to think about a congenital myopathy. So the things that you see that may want you to start thinking about a congenital myopathy include hypotonia at birth. Sometimes this will be called a floppy baby on the report. Sometimes they call it, it's in the form of arthrogryposis. But hypotonia at birth, get your mind thinking about congenital myopathies. Other times, it's going to present later on in childhood or early adolescence. And in this case, it's usually very slowly progressive or even static, that the patient has weakness, but it's never progressed. This is in contrast to the muscular dystrophies that we know are much more progressive and are never static. Or I guess I should say rarely static. Respiratory involvement is also something that should trigger you to start thinking about a congenital myopathy, because respiratory involvement is very common and can even be disproportional to limb muscle weakness. And then the CK is usually normal. It may be slightly elevated, but it's never going to be elevated to the level that you would expect a muscular dystrophy to be. So if you're seeing a normal CK but with weakness, start thinking about a congenital myopathy. There are some exceptions to this classical clinical presentation. And so for those of you who don't practice pediatric muscle pathology, this is actually relevant for you too, because we can see patients presenting for the first time later in childhood, adolescence, or even in adulthood. We have seen a number of cases that present in adulthood. There have been multiple publications, even very recently, about this. And so you can see that this is coming up in the adult neuromuscular clinic and in adults, that where we really need to keep in mind congenital myopathies can be so mild or even start very late in life that we need to be thinking about them as potential entities. Because this clinical severity and presentation can vary a lot, even within one single genetic cause. And this is a chart from one of the papers. And what you can see is that the clinical features can vary based on a childhood onset that's just more slowly progressive versus actually adult onset. And many different parts of the body can be affected, whether that's facial weakness, ptosis, extraocular eye movement issues. There can be problems with the spine, with scoliosis, or proximal muscle weakness, and then that respiratory impairment and cardiac involvement is pretty common. And so even within these, you can see that the pathology then that we're going to see is highly varied. So your acronyms here are listed. So you've got central core disease or multiminicore disease, nemaline myopathy, and central nuclear myopathy. So within each of these clinical features, we can have a wide variety of pathologic diagnoses that are coming out, and those can be due to a lot of different genes. And the differential diagnosis is always very interesting to me because, especially when we're dealing with adults, we might not be thinking about a congenital myopathy, and we might be thinking more about myotonic dystrophy, which is DM1, or a congenital myasthenic syndrome, or mitochondrial conditions, even some muscular dystrophies. So keeping congenital myopathy in your differential, even in adults, is important. So now you've got your clinical history, you start thinking about a congenital myopathy, and you lay down some of the slides. So what are some of the things that can help you think about a congenital myopathy when you start looking at your slides? On H&E, are there two distinct fiber sizes? That could suggest maybe fiber type disproportion. Are there an increased number of internally placed nuclei, suggesting maybe a centronuclear myopathy? Are there cores, which sometimes you can see on H&E, sometimes you can't, but sometimes you can. Are there caps? Is there a lack of significant myonecrosis regeneration and endomesial fibrosis? This would point you more towards a muscular dystrophy. when you look at your fiber typing, is there a type 1 fiber predominance? This is probably the easiest thing to be very, obviously see on your slides, that there's a type 1 fiber predominance. And that really should get you to start thinking about a possible congenital myopathy. And also type 1 fiber atrophy. We see type 2 fiber atrophy in adults a lot due to a lot of various reasons, whether that's disuse or steroid treatment. But a type 1 fiber atrophy is fairly rare. And when you see that, that needs you to start thinking about a congenital myopathy. On your Gamori trichrome stain, are you seeing rods or cores? That'd be pretty obvious and nice if you were seeing them, although you don't always see them really nicely. On your oxidative enzyme stains, again, cores are much more easy to see than they even are on the Gamori trichrome, but sometimes you can pick them out there. And is there abnormal central aggregation of staining, which would suggest that maybe there's a centronuclear myopathy? And I'm going to say it. I say this during every presentation for congenital myopathies, but I really think you should automatically order EM, or at least have a very low threshold to order EM. Every pediatric biopsy, I think, needs EM, just so that to make sure that you're not missing something. But in the congenital myopathies, it's really going to be very, very helpful to confirm what you're seeing, or to identify something you aren't seeing under the light microscope. So what are the common structural abnormalities? We said it's a structural disease most often. So cores are very common, and this is one of the more common things you're going to see. Rods are another form of a structural abnormality in congenital myopathies. Internalized nuclei, as we've mentioned. And then fiber type disproportion, while it's not technically a structural abnormality, we'll touch just a little bit on it at the end so you can get an idea of some tips and some pitfalls for fiber type disproportion, because this can come up and be a part of the other three big ones that I've shown here. So we'll start by looking at the muscle biopsy histopathologic findings, because that's how you're going to start. You're going to be looking under the microscope and see your structural abnormality. And then we're going to talk a little bit after that about the clinical disease and the common genes that can cause that pathology. And we'll start with cores. So this is a wonderful paper that was written by Dr. Shai and Dr. McGee in the 50s, where they first identified a new congenital non-progressive myopathy. And this was described as that there was this aberrant fibrillary bundles in the center of almost every muscle fiber. And they denoted these as being cores, because it's almost like if you have an apple and you've got an apple core and you core out the center of that apple, that's what these looked like to them. An amazing histopathologic image from the 50s. And here again with a Mason's trichrome stain, you can see that there is this big central core there in the center of the fibers. So what are cores? Well, they're areas that lack oxidative enzyme staining because mitochondria are excluded from the core, but there is also myofibrillar or sarcomeric disruption that occurs within that core that leads to altered staining on NADH as well. And so NADH, SDH, and COX are going to be most helpful for recognition. A diagnostic tip, if you've got an older stain around the phosphotungstic acid hematoxylin, or PTAH, it can also be really helpful due to the altered myofibrillar architecture that you see within a core. And this is an example of central cores within a muscle biopsy. You can see there's definitely fiber size variation here. And then you see these areas that look a little bit paler in the center compared to the rest of the myofiber. And there's aggregation of basophilic staining around that. And that's because the mitochondria are all pushed out to the edge of this core. It's not really empty, obviously. It does have myofibrils within it, but they are disorganized and there's no mitochondria within that core. So here's our really helpful NADH staining. When you see this, it's great. You might also start thinking about target fibers, but they are not always this obvious on H&E. So NADH, PTAH, and COX SDH, these are dual COX SDH stains, really nicely highlight the lack of mitochondria within those cores, and then the altered myofibrillar architecture with the PTAH. Also, there's usually a type 1 fiber predominance. So you can see here that there's a type 1 fiber predominance. In addition, the cores are mostly within these smaller atrophic type 1 fibers. And that's very common in central core disease, that the cores are going to be located within those. And then these are there's some hypertrophy here of type 2 fibers. Not always going to be the case, but seen in this patient biopsy. There's another way you can see cores, and those are Minicores, or what they call multiminicore disease. So Minicores are really hard to see on H&E. I've never identified them necessarily on H&E by any means. And I think they're even hard to see on NADH. So these are NADH stains and COX and SDH stains because they really mimic what we might call moth-eaten fibers. There's just altered staining with oxidative enzyme stains and NADH, but it can be very, very subtle. So you can see here that, if you have a biopsy that's not frozen well and you've got some freeze artifact, it might mimic that, but definitely mimics moth-eaten fibers. So this is where EM is very, very helpful to really confirm that these truly are Minicores. On toluidine blue, cores can be identified. Here you can see there's some odd darker staining because this is Z-line material that is aggregating abnormally, and it's a little bit altered there. This is in longitudinal section, and in transverse section, it'll look also darker, but a little bit more disorganized, not obviously a linear like it does on longitudinal section following the sarcomeres. And then under EM, you can have two different kinds of cores that you can identify. In the central core disease, the structured cores are going to be more common. And so this is a little bit more subtle, but if you start out here, you can see nice normal sarcomeres. You can see the mitochondria that are present and a little bit of lipid that's present in between the myofibrils. And when we get here, you can see that there is a lack of mitochondria from here to here. The Z line is not as perfectly straight. It's a little bit raggedy and odd, and maybe set off a bit from the sarcomeres out here. And then you come down here and you can see we're starting to pick up mitochondria again, and the sarcomeres, the Z lines are very nice and straight. So this is what happens with a structured core, much more subtle and difficult to identify. An unstructured core is much easier to see because there's a lot of Z line streaming and a lot of myofibrillar disruption that's more obvious. So this one you're not going to miss. In transverse section, not everyone looks at transverse sections when they select slides for EM, but if you do look at cores in transverse section, this is what they look like. So it's good to know because it's just basically a jumble of disrupted electron dense material. Minicores are much more subtle, as you would expect, because what we're seeing at the light microscopic level is much more subtle, but you can see some Z lines streaming here, here, and here, and here. So this is what Minicores look like. I will say I've seen, what looks like a Minicore or two in non-core myopathies and just, other kinds of myopathies. So seeing one here or there, I wouldn't jump to this diagnosis. You could suggest that it could be a possibility, but if it doesn't seem to fit, I wouldn't jump to it. In true minicore myopathies or multiminicore myopathies, there are numerous of these that are found throughout the muscle fibers. And here's a higher power showing that Z line streaming, and it often affects 1 to 2 sarcomeres. So potential pitfalls, these are really important, is that core-like areas can be seen in other entities. Really, it is difficult to distinguish targets or targetoid change from cores. So you can see here that the central pallor that we saw with our case of central core disease, and then that basophilic stippling out here, this is going to be a nice 3-zoned target. And these are more targetoid areas without a 3-zone, but these really do look like central cores. And even by electron microscopy, they look identical. There's really no way to see it, to distinguish an unstructured core from a target. The thing to do here in this case is really look at the real estate, look at the neighborhood that this muscle fiber is in. Are there a lot of other evidence of neurogenic change? Are there pycnotic nuclear clusters? Are there groups of angular atrophic fibers? If so, you're more likely dealing with targets. If not, then you may be considering more cores. However, That being said, I have seen numerous cases where in some forms of dermatomyositis or other inflammatory myopathies, idiopathic inflammatory myopathies, there are areas that are devoid of oxidative enzyme staining. And even on EM, these look identical to cores in a congenital myopathy. And so these can really throw you off as well. The thing to do, I think, is just include this, this possibility in your comment to discuss it, to bring it up, but it's probably unlikely when you have otherwise neurogenic atrophy or otherwise another diagnosis of something like an idiopathic inflammatory myopathy. So from a clinical perspective, core myopathy is an all-encompassing term for central core disease. Minicore disease, multiminicore disease, those are usually combined, and dusty core disease, which is a newish form of RYR1 disease. Highly clinically, pathologically, and genetically heterogeneous. All of them are. So central core disease, usually you're going to have type 1 fiber predominance like we had in the case that we discussed. It can be so extreme that you have congenital neuromuscular disease with uniform type 1 fibers. So this is what Nishino called it in his paper, CNMDU1. I'll show you that paper in a moment. And actually, when they look at patients who have the same RYR1 mutation that have central core disease, the younger patients in the family, when they biopsy them, may only show uniform type 1 fibers. So over 99% or more of just type 1 fibers. And then when they're older biopsies from older patients in the same family, they have cores. And so there's a theory that maybe fiber type conversion precedes core formation. I don't think it's definitively proven, but there's some evidence to support that idea. As I mentioned, cores have a predilection for type 1 fibers. In central core disease, they're single cores classically, they're centrally placed. They extend along the length of a myofiber in longitudinal sections, and here's that nice structured core here. Here's a little bit more of a slightly unstructured core, but still you can see a little bit more maintenance of that structure. And in autosomal recessive forms of central core disease, which are less common, you can also have increased centrally placed nuclei. RYR1 is the causative gene for central core disease. Most of the cases, as I said, are autosomal dominant, but some autosomal recessive forms have been described. And the clinical phenotype can be a little bit varied. Autosomal dominant RYR1 related disease shows early onset hypotonia and or motor delay, but the severity can be highly variable, and even patients can present up to adulthood, even with autosomal dominant RYR1 related disease. Weakness is often axial, pronounced in the hip girdles. It can involve facial weakness and joint laxity to make you think it maybe is a collagen 6 disease. You can even have ophthalmoplegia and bulbar involvement, particularly with autosomal recessive RYR1 related disease. And this is usually very stable or slowly progressive clinical presentation. And you can see that RYR1 can cause different pathological features. While it is the most common one to cause central core disease, it can also cause multiminicore disease, uniform type 1 fibers, rods and core disease, fiber type disproportion, and dusty core disease. And this is that paper I was mentioning from Nishino et al. That describe congenital neuromuscular disease with uniform type 1 fibers and an RYR1 mutation. And this is when you really do have more than 99% of type 1 muscle fibers. Here's an example of a case that we saw where you've got your slow myosin heavy chain highlighting a type 1 fibers and your fast myosin heavy chain highlighting this one little fiber here more definitively as being a type 2 fiber. And then what's staining over here is actually a muscle spindle. So the muscle spindle stains normally, that's got some nice type 2 fibers in it, but the rest of the muscle itself had very, very few type 2 fibers. You have to also keep in mind malignant hyperthermia, because pathogenic variants in RYR1 can lead to malignant hyperthermia susceptibility trait. So if you are thinking about it, you've got a patient you know as RYR1 disease, it's great to mention it in your comment to make sure that the clinicians are keeping that in mind. The problem with malignant hyperthermia is that if a patient has been exposed to anesthetics via inhalation, they can have muscle rigidity and increased body temperature, and it can lead to death. So the clinical communication tip for malignant hyperthermia, because this is going to happen if it hasn't already happened to you, that this is actually diagnosed with fresh tissue sent to a lab that performs a caffeine halothane contracture test. So you cannot diagnose malignant hyperthermia on a muscle biopsy that's sent to you. That has to be done at the specific lab that does this test, and that fresh tissue has to go directly to the lab to perform that testing. So it's unfortunately there's a little bit of misunderstanding with some neurologists about this, and they'll send muscle biopsies and say, please evaluate for malignant hyperthermia, but we can't really do that. We can look for other forms of RYRI disease, but not malignant hyperthermia. And then the next most common core disease is multiminicore disease that has these multiple small areas devoid of oxidative enzyme staining we saw. It can be easily overlooked or show overlap with moth-eaten fibers. And they can be in either type 1 or type 2 fibers, different from RYR1. And then the disruption of the Z lines or myofibrils involves only a few sarcomeres, and it can be caused by a lot of different genes here. You can see all of the different genes that can cause multiminicore disease. Selenon is the most common gene that causes multiminicore disease. Previously, this was called SEPin1, encodes selenoprotein, and these are usually presenting in early neonatal period or early childhood most commonly. They have axial myopathy with scoliosis and respiratory failure, and the multiminicores are what you really are going to see with SEPin1 or Selenon myopathies. Okay, now we're going to move on to rods, and you can see these beautiful rods here. So what are they? They are elongated electron dense inclusions. We call them nemaline rods. They're derived from Z lines, and they maintain the lattice-like structure that we see in normal Z lines. So what you can see here is this internal lattice that's hatching almost of this. Z lines have that normally, and the rods do as well. They also have the thin filaments coming off either end of them. On H&E, they can be impossible to see. You're not necessarily going to find rods just by doing an H&E stain. Sometimes you can have some clues. Sometimes there are cap-like areas or a clearing in the subcirculamal space that's a suggestion there could be something within there, and you can use that. But trichrome is definitely the most helpful stain from the light microscopic perspective to identify nemaline rods. However, for definitive identification, EM is what you need to do. These can be stained with other things like alpha-actinin, myotilin, nebulin, and phalloidin based on their properties. However, these are not usually used very frequently in actual clinical practice. You can, but EM is really the best way to go. So here's an example where you've got a little bit of a suggestion on H&E that there's something going on in the subcirculamal space of that fiber there. This one, in this case, this was a little bit darker staining. This is a little bit lighter. This is a little bit darker. It can look both ways. And then here, what you see is there are nemaline rods packed into that subcirculamal space. Now, rods aren't always subcirculamal. They can be internal. I'll show you some examples of that. There's some nemaline rods in this one too. They can also be within nuclei, but here you can see that most of the time they are in the subcirculamal space, at least most commonly. So we don't often get a chance to look at a lot of different rods from a lot of different cases. So I thought this would be a great way to show many-faced rods, just like for you Game of Thrones fans, for the many-faced gods. So these are the many-faced rods. So I'm just going to show you a selection of different cases and what the rods look like in those cases. Most of these are the frozen sections that are stained with the modified Gamori trichrome stain. And you can see the variation in the color of these rods is quite significant. And then we'll also start looking at some epon sections stained with toluidine blue here. So you can see what rods can look like with epon sections as well. And you can see some of them are large, like these are very large. Some of them are much smaller. In the books, they show pictures of them. Oftentimes they look really dark in color or black in color on in the books, but then they will say in the text, oh, they usually are pink or red or purple. And I've seen them look black. I've seen them look dark blue. I've seen them look pink. I've seen them look purple. So they really, depending on the way you do your modified Gamori trichrome and probably a little bit of the internal structure of the rods themselves, they can have a really wide variation in their color. So don't let that throw you off. If you're suspicious that something could be a rod, do EM and confirm it at the ultrastructural level. One pitfall is that they can be extremely focal. So you can see no rods in your trichrome stain, and then you can find 5 or 6 in your epon sections or through EM. So that's why I really suggest EM. And this is what rods can look like on EM. So we talk about nemaline rods because they have that rod structure. Some people will also use the term nemaline bodies when they're not very rod-like, when they're more rounded. Sometimes when they're rounded, you're just cutting them in cross-section, but sometimes they even look less rod-like at longitudinal section. So you can use the term bodies if you'd like as well. But here's a nice variation of different ways that rods can look under with EM. Now, there are some pitfalls. There are some lookalikes that you need to be aware of. One of them is a rod versus a cytoplasmic body. So here is a cytoplasmic body on EM, and you can see it's a dense filamentous core with a surrounding lighter halo and filaments kind of going all circumferentially all the way around it. And this is what a rod looks like. Also electron dense center, although the rods are more longitudinally extended away from it and have a little bit more electron density, more structure to the center of them. Cytoplasmic bodies are a little fainter here. So here's another example of cytoplasmic bodies that are darker, but you can see that they are in contrast to the nemaline rods. And just as a reminder, this is what cytoplasmic bodies look like on the trichrome stain, which is very different than what you would expect nemaline rods to look like. Another pitfall that I've come across, and in only one case that I've seen, but it's listed in the myology book, is these giant abnormal lysosomes. So rarely you will see this. Maybe other people have seen it more, but abnormal lysosomes can really have a resemblance to a rod. They have a dense filamentous core. However, they're membrane bound because they're lysosomes. So that's going to really be the key to look at high power, make sure that if these have a membrane, then they're not going to be a nemaline rod. And this is the picture from the book, from the myology book. This is the case that I had. Rods do not always equal congenital myopathy. So this is our other pitfall to really be aware of. Include this in your reports for sure. Rods can be present in other situations. If you're looking at normal myotendinous junction, you can find nemaline rods. So you will be able to recognize histologically what normal myotendinous junction looks like and ignore any rods that you see within that area. If you're looking at extraocular muscles, every once in a while, someone will decide to biopsy an extraocular muscle looking for a mitochondrial myopathy or something. Then, don't worry too much about nemaline rods being present in extraocular muscles. That's okay. If you're dealing with an HIV-associated nemaline myopathy, that's not a congenital myopathy, but there definitely are rods present. And you can see this is an example from Dr. Moore that he showed a lot of nemaline rods present in this muscle that was due to HIV. And then there's also an entity called sporadic late onset nemaline myopathy that is not a genetic form. It is highly associated with a monoclonal gammopathy of uncertain or undetermined significance, an MGUS. There are cases that don't have an MGUS that they still call SLONM. But here's an example that Dr. Boris sent me from Loyola, a really nice example of beautiful nemaline rods in a case with an MGUS. And from a clinical perspective, there are now at least 12 genes that encode structural or regulatory proteins of the thin filament that cause nemaline myopathy. We saw in that nice diagram at the beginning. ACTA1 and nebulin are by far and away the most common ones that you're going to see. And like anything else, there's a wide variation in clinical and histologic pictures. And respiratory involvement is very common in these patients, unfortunately, and can lead to mortality, despite the fact that these are often not very progressive or more static. There's a paper that came out in 2021 where they really wanted to classify these nemaline myopathies as severe, typical, mild, have a more structured clinical classification system. But what you can see here too is that the genes are really highly variable, but the clinical features can be also just as variable. So just important to keep in mind from a clinical perspective. And what about internalized nuclei? So normal muscle can have up to about 3% of the fibers showing internal nuclei and transverse section. When we have increased internalized nuclei, we think of that as a non-specific myopathic change, but it can also be a sign of a congenital myopathy. So keep that in the back of your mind. The congenital myopathies that we most commonly think of are centronuclear or myotubular myopathy. And this is an example on the left of a patient with centronuclear myopathy, and this is a patient on the right with myotubular myopathy. When they are very centrally placed, that should even raise your concern more, even for a congenital myopathy versus just multiple internal nuclei, although that can also be seen. So what you can see, there's some variations here. So in X-linked myotubular myopathy, we see nice central nuclei, very big centrally placed nuclei, often in these muscle fibers. So that's pretty easy. And you would definitely be concerned of a congenital myopathy when you see this. The centronuclear myopathy is due to DNM2 alterations are a little bit more difficult. Sometimes they look like a single centrally placed nucleus and it's helpful, like in these two bottom cases, but sometimes it's just a lot of internal nuclei. And this you might be thinking is just a normal non-specific myopathic change. So important to know a little bit about the clinical history and keep this in mind when you're seeing a lot of internalized nuclei. One pitfall that we've seen is that you can actually have vacuoles surrounding or adjacent to a nucleus. And so this is a case of a TTN centronuclear myopathy or Titan-related centronuclear myopathy. And because of the freeze artifact that occurred in this case, what you see is that these big holes are here, but actually this really dark staining is these are nuclei. And so the nuclei can be present there adjacent to the vacuoles or within the vacuoles. And sometimes a paraffin section can be really helpful if this case is the one that you're presented with, to show that there really are internalized or centrally placed nuclei. These can be due to multiple different genes, but again, the most common are going to be myotubular myopathy, MTM1 or X-linked MTM, and centronuclear myopathy due to DNM2 autosomal dominant alterations. RYR1 shows up here again because it can also cause a centronuclear myopathy, and you can see that the proteins that are associated with these. So as I said, the most common forms are myotubular and centronuclear myopathy. Myotubular myopathy is X-linked recessive, and the central nuclei are regularly spaced down the length of the fibers. A clue to the diagnosis for MTM1 is that there's going to often be abnormal central aggregation of organelles. And so on oxidative enzyme stains, you're going to have a very dark center with a pale halo around it. And that, like as you can see here, a dark center and a pale halo, because all the organelles are aggregating in the center of the myofiber near where those central nuclei are going to be. In contrast, excuse me, and then necklace fibers can also be a clue, which I'll show you in a moment, in mild patients or in female carriers of MTM1. Centronuclear myopathy is autosomal dominant with central nuclei sometimes in chains and subsarcolemmal nuclei. And this also has necklace fibers, but the necklace fibers here do not have a nucleus, and I'll show you what that looks like. And then radiating strands are another thing that can help you think about centronuclear myopathy. So you see there's a central nucleus here. And on this PAS stain, you see these radiating strands coming out like almost spokes on a wheel or something coming out from that central nucleus. And that should be a clue to you that you maybe are dealing with a centronuclear myopathy. So tips for diagnosis, what are these necklace fibers? Well, this came out in 2009 as a new histological marker, and it is very helpful if you see it. So on H&E, you can see a slight basophilia here with a nucleus there, and this is a PAS stain, this is a Cox stain. You can see on multiple different stains, these organelles actually aggregate in a very circular way. And you can see on EM that this is an aggregation of mitochondria, sarcoplasmic reticulum, and glycogen granules that leads to this pattern that you can catch on many of your histochemical stains. Most commonly, at least when it was first described, we were thinking of this in DNM2 mutations and mild MTM1 patients. We realized that there are like the female carriers of MTM1 that are not necessarily affected in the way that the young boys are. They can also present with necklace fibers and a mild myopathy. And this is what they've looked like in some of the cases that I've seen. PAS is really helpful to identify these necklace fibers and the radiating strands. Here's an NADH, again, a PAS. So I think of it as a necklace with a pearl on the end of it. That's the nucleus there. And in DNM2, they say that you don't have the nucleus, you don't have that pearl. It's just a single necklace without anything on it. However, I think that it's not really that specific and easy to just say absolutely not, no nucleus in DNM2, but these are the radiating strands again here. So helpful feature, if you see those things, be thinking about a centronuclear or a myotubular myopathy. And then just to finish up, we'll just briefly talk about fiber type disproportion. Again, not necessarily a structural abnormality, but important because it is fairly common to see. And what fiber type disproportion means is that there's uniform smallness of type 1 fibers. It can be seen in isolation as its own entity. We've called this congenital fiber type disproportion for many years. I think most people are getting away from using the congenital and now just calling it fiber type disproportion, but it can also be seen in conjunction with cores, rods, central nuclei, caps. So if most people will use the term congenital fiber type disproportion when that is the only finding, when there's only uniform smallness of type 1 fibers. But if you're seeing it in conjunction with these other structural abnormalities, people don't often call it congenital fiber type disproportion. When you see it without any other structural alteration, the genes that are most commonly implicated are going to be ACTA1, a couple of the tropomyosin genes, selenon again, MYH7 and RYR1 showing up a lot. And it's important to think about atrophy versus hypertrophy. We are so used to saying the muscle fibers look atrophic, but when we're dealing with kids, we're dealing with these young children, they likely aren't actually undergoing atrophy. The fibers just have never achieved normal size. So they are hypotrophic or small. You could use the term small. So I would caution you against using the term atrophy in these cases. And one way you can actually know whether there is atrophy versus hypertrophy is that if a fiber has undergone atrophy, the basal lamina is still the same size. And so you can actually see that ruffling or the extra redundant basal lamina versus hypertrophy. The basal lamina has maintained its size with the size of the fiber. So you won't see that extra ruffling or redundant basal lamina. A pitfall here that this was initially described using ATPase stains, and many of us are no longer using ATPase stains. We're using slow and fast myosin heavy chains for fiber typing. So sometimes there's this dual expression of slow and fast myosin, especially in kids. So it makes it a little bit difficult to identify. So one thing that can help is you can actually photograph stains side by side, and I'll show you an example of that. So here we have slow myosin at the top, fast myosin at the bottom. So type 1 fibers, type 2 fibers. And every fiber here that is starred is actually a hybrid fiber. It's expressing both slow and fast myosin heavy chains. However, the ones that are numbered are only expressing slow myosin heavy chain. So this is a case that actually did show smallness of type 1 fibers, but it was hard to tell until you photographed it and looked at it side by side and really tried to take in, are some of these the larger fibers hybrid fibers, and they were. NADH can also be helpful. We always say you can't do fiber typing on NADH. But that being said, what you see here, this is that same case we were just looking at, is the fibers that are truly type 1s, that are more oxidative, that have more mitochondria, that are type 1 fibers, they are smaller than the type 2s. So, that fiber type disproportion is much more obvious, and your other stains can kind of help you with that, although you shouldn't use that really for true fiber typing. Here's another case, and this is actually a TPM3 related nemaline myopathy. And so we wouldn't necessarily call this congenital fiber type disproportion because it was a nemaline myopathy, but what you can see is that the type 1 fibers were smaller than the type 2 fibers. And this was the case that actually Nicole presented that is an adult. A last little remembrance here is that overlapping pathologic features can occur. We've been touching on this a little bit, but you can see cores with rods with caps, fiber type disproportion with a lot of different things, and central nuclear myopathy with cores. So just because you see nemaline rods doesn't mean you're done. Look for your cores, still look for other things. And a lot of the genes can have overlapping pathologic features. So we will, I'm going to just jump over here, new share to our path presenter. So we have a case that is a 48-year-old woman. She has muscle weakness that began around 5 years of age that progressed slowly, and she was wheelchair bound in her 30s. Her exam showed proximal and distal muscle weakness, and her CK level has always been normal. So reading this history, you do start wondering about a congenital myopathy. We're talking about someone with very, very slowly progressive muscle weakness. It has progressed, but it's very slowly progressive. She's now presenting in her 40s to really understand what's going on with her. She's got a normal CK. So I will pull up the path presenter slide. And are you all seeing the path presenter slide?
Yeah, we
Great.
can see it.
Thank you. Okay, and so this is obviously, this was not easy to cut, this muscle biopsy. It definitely had some problems because there was a lot of fatty infiltration. And so one of the first things that you will notice if you come over here to where it's better oriented, this was also clearly difficult to orient, is that there is some fiber size variation. You have some fibers that are smaller, some that are very small, and some that are much larger. And then we have an increased internalized nuclei, right? So these are significantly increased internalized nuclei, a little bit of splitting as another non-specific myopathic change. But then very subtly, similar to what we were seeing in one of our nemaline myopathy cases, it looks like there might be a little bit of something odd here in the subcercolemmal space, a little bit of clearing. Maybe there's something that's going to be present. Whenever I see that, I really jump to my trichrome. I want to know what's going to be in that space. Is there anything that's going to be helpful in that space? And then the addition of seeing a lot of increased internalized nuclei also is interesting finding when we're thinking about a congenital myopathy, and you can see that they're lining up here in chains. So this is very concerning for a congenital myopathy, not only based on the clinical history, but also now based on what we're seeing under the microscope. And if we go back to our PowerPoint, I will show you what the stains looked like. And so here we have a Cox SDH stain and an NADH stain. And surprisingly, something we didn't see on the H&E at all is that there are large areas that are devoid of oxidative enzyme staining that look like cores. And then we also found on the trichrome stain really beautiful nemaline rods, and exactly in those locations that we were suspicious about based on H&E. And further electron microscopy confirms that these really do look like areas that could be true cores. Although in theory, you could be concerned about targets in an adult. However, there was no real neurogenic change in that biopsy to make you really concerned about neurogenic change. These really do look more like cores. And then these nemaline rods were nicely confirmed by electron microscopy. This electron dense rod-like structure, it had a lattice structure when you get on higher power with filaments coming off either side. And it turns out this patient actually had homozygous pathogenic variants in the gene called PAROXD1. It's a very newly described congenital myopathy related gene. You can see this paper, I think, is from 2019. And the pathologic findings that they see in this paper include fiber size variability with endomesial fibrosis, internalized nuclei like we have in our case. They saw cores as well, rods, and what they called myofibrillar disorganization or myofibrillar inclusions. Our patient didn't necessarily have myofibrillar inclusions, but she definitely had cores and fits very nicely with what they were describing for PAROXD1 related myopathy. Okay, that is our whirlwind tour of congenital myopathies. I'm happy to take questions.
Yes, thank you, Dr. Jones. At this time, we're going to move into Q&A. You can submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat, please ensure the message is to everyone so that both the presenters and attendees are able to see the question. And to unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise.
Okay, so I see some questions here. So Dr. Klonowski, good to hear from you. How do you deal with a case that has cores and rods? Is core rod myopathy, C comments, a decent approach, or do you have some suggestions? Absolutely, yeah. You can say, myopathic change with cores and nemaline rods, or you could just call it flat out a core rod myopathy. That is a very legitimate diagnosis. And then, yeah, add comments in suggesting that, congenital myopathy gene panel would be most helpful in that case to try to figure out what the gene of interest could be. And Dr. Cosmes, can you see any inflammation or high CK in congenital myopathy? What does it mean if it is present? So you can rarely see a little bit of inflammation. You're not in a classic congenital myopathy, you're not going to see a lot, but just like in muscular dystrophies, you can always have a little bit of inflammation. And the CK can be slightly elevated, but I wouldn't expect it to be more than 400 or 500 unless there's a really odd situation. But usually it's not over 1,000 for sure. And what does it mean if it's present? I don't know. That's something that I don't have an answer to. I do know that we see it in other genetic muscular dystrophies that are not inflammatory myopathies and other genetic diseases, like even metabolic myopathies, we can see them. So I don't put too much stock in it if it's a little bit of inflammation or a slightly high CK when we have otherwise diagnostic information for pointing towards a congenital myopathy. And Dr. Perez Rosendahl says, regarding type 1 fiber smallness, fiber type disproportion, what criteria do you use for the degree of type 1 fiber smallness? I know the percentage varies in the literature between 12 and 25%. I agree. So they do suggest that there is this specific percentage that that fibers need to be. Some people say it needs to be less than 12% or greater than 12% difference. Others say are a little more generous and say 25% difference. Honestly, I don't really like a specific cutoff. I will. I just don't like a specific cutoff. I don't have any evidence to support one of those percentages over another. So I think anywhere around that range is fine, at least to even suggest it. I mean, we don't have to necessarily call it if it's a little bit borderline, but to suggest that there's type 1 fiber smallness, it doesn't hurt even if it doesn't fit right within those exact percentages, but that's just my opinion. Okay, and then Dr. Wells says, how does genome, transcriptome, methylome, proteome sequencing fit into diagnosis? That is a fabulous question. I haven't done any reading up on the transcriptomes or methylomes or proteomes of these diseases. I am a simple more clinical neuropathologist, and so I don't have a good answer, but if anyone else does, I'd be happy to hear about it. And then we have another question from Dr. Cuevas Acampo. A bit off topic, I wondered, what is your preference when it comes to IHC antibodies for myosins? We were trying to replace the ATPases in our lab. Yeah, so I can email you offline. I think you did email me and I haven't responded. I'm so sorry. Yeah, I will email you offline to let you know what we're using.
Did we have any other questions? Oh, Dr. Gilbert, did you have a question?
Yes, sorry, I was trying to write it quickly and then I don't type that fast. Dr. Jones, what is your preference regarding going back to the IHC stain for the myosins? What are the benefits of using the IHC stain for the fast and slow myosins over the ATPase? And if we're currently just using the ATPase stains, is there a significant benefit to using the fast and slow myosin, given the fact that they can sometimes overlap?
Yeah, that's a great question. So I think that the reasoning to get away from the ATPases is that that they are technically extremely challenging, and that there's a lot of variability, at least in the labs that I've worked in before. There's a lot of variability in the performance of those antibodies, and so it can be really frustrating, as you know, to like sit down and the ATPases didn't work and have to redo them. They're also some of the chemicals are highly toxic, and so some labs don't want to be purchasing those chemicals needed to perform the testing, and so another reason, although it probably not as significant, is that they can fade over time, and so the IHC is a little bit stronger to last for a longer amount of time. But the IHC is easier to do. While there is overlap, I don't find that to be enough of a problem that I would want to go back to the ATPases. I really, really like having the antibodies. And then Dr. Cohen says, for what it's worth, we do both fast and slow on one slide with different chromogens. Yes, I have seen that before, and it's beautiful using a brown and a red chromogen, and then you can look at it right there side by side. Pretty lovely. And are there questions I've missed here? Oh yeah, and Dr. Bourne says the same thing. Dual color, fast and slow myosin on one side. Yep. Yeah, those are really lovely.
All right, I think we are out of time for today. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website the next week. Thank you again, Dr. Jones, for an excellent presentation. This concludes the session for today.
Thanks, everyone.
Hi, everybody.